Hello, and welcome to another episode of Talking All Things Cardiopulm. I am your host, Dr. Burriesci. Before we get started, I'd like to take a moment to highlight our sponsor, Jane. Jane is a complete practice management software that makes it easy to book, chart, bill, and get paid all online. The team at Jane knows that getting paid is one, if not the most important part of running your practice. With that in mind, they've created a fully integrated PCI-compliant payment solutions called Jane Payments. That makes for a convenient online payment experience for you and your patients. With Jane Payments, you can collect credit card information through your online booking or intake forms, send one-click payment request emails or SMS text for outstanding balances, and you'll never have to leave Jane to reconcile payments. Curious to learn more? Head to jane.app/payments. You can also use the code CardioPulm1MO at the time of sign up for a 1-month grace period on your new Jane account. A small gift from Jane to you. So thank you again, Jane, for sponsoring this podcast. If you are on YouTube, you might notice that I have on the over-the-ears headphones today. I've made a switch back actually for 2 reasons. So the first reason is actually related to some cranial nerve work that I've been doing and learning that even just having headphones in the ears can make differences with cranial nerves. So we're trying our best to utilize them the least amount. And number 2, I feel like my sound has been a bit off on podcast. I'm just going to make some noise for a second. So I'm hoping this will take some of that out. So we'll see. Today's the first day back on the over-the-ears. I used to wear them prior to going on video. So here we are, giving them a try again. So today I wanted to talk about peripheral arterial disease. PAD is a diagnosis that you pretty much see in a good number of patients in their comorbidity list. In the hospital setting, you might specifically see them for a peripheral arterial disease intervention, like if someone comes in for stenting or even assessment of their PAD and they're doing ultrasonography looking for how much how much occlusion exists. And typically when we see them in the acute care setting, they are coming in because they're either not well managed, they have chronic wounds, or they're at the decision where we need to make the next decision. And these patients tend to end up as our amputees. And we typically see these patients quite a bit. You might see them in for chronic toe wound. They note osteomyelitis. They then end up with an amputation of their toe. They go home, they're managed for a bit. You may see them a few years later. Now they're in for a transmet. They have a TMA. Further down the line might be a BK versus an AKA. This is someone that you might see as what we call a frequent flyer, or you might have the person where they make the decision to amputate higher earlier. And I've had a number of patients recently that are either post-amputation, toe amps, chronic wounds, and just the PAD patient that happens to have other comorbidities that brought them into the hospital. And I really think it's important for us to understand the pathophys, what we as PTs can do, and how we can help them prevent that later sequelae, right? It always starts with that prevention, education. Can we make a difference earlier? Sometimes yes, right? If we get that person sooner and we have the ability to educate, I want to say that yes, we can truly make a difference. But sometimes, depending on when we're meeting them or in what process, whether they're outpatient versus inpatient versus the acute setting, you might have different goals for that patient. So the first thing I just want to talk about is the pathophys, right? Some people get really bogged down with that word, but I find that when we break it down to its most simplistic cause, then we're able to help more efficiently. And so with PAD, the primary thing that is happening is that we have atherosclerosis in the peripheral arteries. So we have buildup of atheromas and plaque. And eventually, over time and years, we have an occlusion that starts to impede blood flow. So a lot of patients have PAD and may not know it until they get to the point where demand is not meeting demand is not meeting the activity. And when we have that imbalance is typically when patients start to feel pain. And that's usually what triggers patients to come in. So atherosclerosis in our peripheral arteries, this could be upper extremities, this could be lower extremities, it could be all of the arteries, right? And this is an important point that I want to make. The pathophysiologic process of PAD is the same as CAD. It's the same issue. So most of the risk factors mirror CAD, minus there's some like age differences that occur. But for the most part, you can just put them up side by side and they're pretty much the same thing, which means that if we can educate early on the benefits of exercise and eating habits and medication management and smoking, which is still one of the biggest causes of PAD, then we can really make a difference for the person long term, which I think is always the goal. So our patients with PAD have atherosclerosis in their peripheral arteries, and it starts to impede blood flow. And what happens is they're doing something like walking, and they end up with pain because the demand isn't meeting the supply. Okay. We're asking for more as we do more exercise, and we don't have the supply to get there. So what does that sound like? That sounds like the definition of angina. We don't call it angina when it's in the legs. We call it intermittent claudication. But essentially, intermittent claudication is angina in the legs. It's exactly what it is. Why that patient is feeling pain is because they're being deprived of oxygen to the tissues. We need blood flow, oxygen delivered to muscles in order for them to perform. When we have lack of oxygen, we're basically experiencing ischemia. And that is painful. It becomes very painful. So most patients that have PAD complain of pain in their calf. That is probably the most common place that I hear, but it can occur in the thighs, it can occur up in the buttocks, and it could even occur a bit higher. Just depends where the primary occlusion is. So depending which artery is most occluded depends on where you're going to feel that pain. So similar to angina, intermittent claudication basically is very predictable. At a certain distance, at a certain activity level, at a certain time, that pain is going to get too bad for that patient to continue. So when the demand is greater than the supply, they feel the intermittent claudication. When we have that reproducible, very specific distance, time, that is the cause, right? So what makes it worse? Typically activity. Walking is usually the most common complaint. I can walk one block. Once I walk one block, I can't go any further. I have to sit down to recover. What makes it better? Rest. What makes it worse? Elevating the legs, right? So if we have arterial disease, we have occlusion in the arteries, that's going to the muscle. If we elevate, we're going to have a harder time going distally, and that's going to make the pain worse. And we'll talk a little bit later. That's one of the tests that you can do to help provoke intermittent claudication to basically assess for PAD. But it's reproducible. And when they feel it, they tend to feel pain, achiness, tiredness, fatigue in the legs. It's typically one over the other. Some patients will have it bilaterally, but it's very commonly on one side, and it's very commonly very specific. 2 blocks, 1 flight of stairs, 10 minutes on the treadmill, whatever the tipping point is, it's very reproducible, which makes it wonderful to rehab. And that's exactly what we want to know when we start working with these patients. Back to what makes it better. Rest, that's number 1. And number 2 is legs in the dependent position. So if elevation makes it worse, legs in the down position will make it better, because essentially gravity is helping bring blood down to those muscles. So when we're working with this patient, we want to use a scale called the PVD scale, Peripheral Vascular Disease Scale. I don't know why it's not called the PAD scale, because we don't use the scale with venous disease. So mind-boggling, but here it is. It's called the PVD scale. It is a 0 to 4 scale. And we're going to use this scale to basically provoke intermittent claudication. We're going to use this scale to create exercise prescription. For all my students out there, if you have a case with peripheral arterial disease and you want to know what intensity to work that patient with, we're going to be using the PVD scale. Everything else is secondary, because when you're exercising this patient, this is going to be what causes them to quit over everything else. Okay. So looking at the PVD scale, we're looking at a 0 to 4 scale, and we're going to be teaching our patient to use the scale in their regular everyday life when we're teaching them their exercise prescription. So the earlier you can introduce the scale, the better it is. And again, this is the primary scale. Everything else comes secondary. So grade 0 is no claudication. Grade 1 is initial discomfort, at minimal levels of discomfort. Noticeable is a good word. They can keep going. Grade 2, moderate discomfort, but the patient's attention can be diverted, for instance, with conversation. Grade 3, intense pain. It's just short of grade 4, and the patient's attention can no longer be diverted. And then lastly is grade 4, and that's excruciating and unbearable pain. We're going to be pushing that patient to 3. This is probably one of the only diagnoses in the world of PT where we actually push people into pain, but there is a lot of benefit to doing so. So grade 3 is what we are pushing our patients from an intensity level with PAD. So why are we doing that? So exercise is such a wonderful tool, and I'm going to keep saying this because it is the magic pill. If we can make it a daily occurrence, if we can meet the minimal activity levels of ACSM, we're going to help our patients make change in their physiology for whatever comorbidity they have. But specifically with PAD, it has the ability to actually help increase angiogenesis around said occlusion. So exercise and pushing into that pain point actually has a ton of benefits, not just, no pain, no gain. Literally, never use those words with a patient, but this is the one patient population that actually will benefit from pushing them into that 3. That's your stop though. Okay, we're never getting to the 4 where it's excruciating, where you can't pull back from, where you're not going to be able to rest and recover. So increasing angiogenesis or collateral circulation, basically creating blood vessels around said occlusion, is the number one benefit of exercise in this patient population. We can also increase capillary density in that area, which is going to help overall oxygen delivery to the musculature. We're going to improve muscular efficiency. The body just gets more capable of creating energy, accepting oxygen, and doing the work. Efficiency is probably one of the number one benefits of exercise with this patient population, and that's aerobic and strength training. It also helps increase the pain threshold. So the patient gets more comfortable pushing into that 3. Eventually, they're going to be able to go a little bit further and then hit the 3. So there is a little bit of pain tolerance that does come across in this. Decreased blood viscosity is also on the list of benefit. But at the end of the day, quality of life and improvement of their overall activity level is the number one reason why we are helping our patients do more. From a physiology perspective, the most, I think, amazing thing that exercise does is angiogenesis. Like literally, we're helping improve blood flow to that area that is no longer getting good oxygenation. When we're talking about exercise prescription with this patient, depending on where they're at in their disease process, is this an early diagnosis? Do they have severe disease? Do they already have chronic wounds? And we'll go into the severity scale in a second. But this all depends, right? Depending on where they are in that process depends on how far they're going to be able to push into that 3, literally from a distance perspective, time perspective, and literally what I'm saying is the intervals. So with this patient population, interval training is key. Interval training into a 3 out of 4 pain is your interval, essentially. So if you're writing up an exercise prescription or you're working with a patient, you're trying to figure out how to get them to do more, the answer is intervals. If the person is very severe, this might be a very small distance. 100 feet, stop, rest. Once that pain has resolved, 100 feet, stop, rest, keep going, okay? If your person is working at such a low level, the number of times in a day, the frequency of exercise in a day likely will be more. But we also know that this is probably going to be less possible for the patient in real life. Doing something more than 3 times a day is a big ask for most patients. But if it's taking less time in each interval, you have a higher probability of it happening. So they're doing really small intervals, higher frequency in the day, but typically some period of 1 to 2 times a day is about what the patient will be doing. And the goal is for 7 days a week. So with this patient population, more is literally better, especially if we're in that very small time frame. Eventually, once they're at a higher level frequency or a higher level time with their exercise routine, whether it's in distance or time, like say they can officially go 30 minutes continuously, then you can pull that back to regular ACSM guidelines. So 3 to 5 days a week for 20 to 30 minutes with the end goal of being 60 minutes. So longer is better for this patient population. Interval training progresses into continuous training based on your patient's response. I promise you, if you go low and slow in the beginning, you're going to have more buy-in and better retention long-term. What types of exercises should they be doing? From an aerobic perspective, something that they like. So walking is probably the most beneficial because that's typically where they feel the most pain. But we have to look at the whole picture. Do they have chronic wounds? Do we have a poor healing wound? Do we have such pain that we can't go more than 50 feet at a time? Then you might want to pivot to something different like biking. And there's a really cool article, I should have pulled it before starting this, that doing upper extremity ergometer exercises in patients with PAD can improve their lower extremity blood flow even if they're exercising upper extremity. So that's phenomenal. Basically, you're trying to improve the aerobic capacity because the patient is going to become more efficient with their exercise, with whatever they're doing. I also highly recommend to include strength training with this patient population. Very similar to the aerobic benefits, collateral circulation, improvement in capillary density, efficiency at the cellular level at the muscle will occur with strength training, and always stick to major muscle groups. Strength, aerobic intervals is your go-to with this patient population. So I'm going to back up a little bit and talk a little bit about the severity of the disease and how we figure this all out. So there are a number of diagnostic tests that you might see with the peripheral arterial disease population. ABI is probably the most trigger word. And ABIs are really cool because as PATs, if we have access to a Doppler, then we can actually perform ABIs on our patient. And based on the ABI number actually tells us the severity of disease. So if you were to do an ABI, an ankle brachial index test, essentially what you're doing is comparing blood pressure of the lower extremities to the upper extremities. So the way that you perform this is by taking blood pressure of right and left arm and keeping the higher number. That higher number becomes your number that you input into the formula throughout the rest of your testing. Then you take blood pressure using, again, the Doppler at the posterior tib and dorsalis pedis arteries on both feet. You take the higher of the two, dorsalis versus posterior tib, for each foot. And typically you're comparing legs so that you can actually see if there's disease symmetrically or on one side. So ABI is systolic blood pressure of lower extremity over upper extremity, and you're taking the higher of both leg and arm. Normal ABI is 1.0 to 1.39, considered normal. When we go above 1.4, technically that's showing some sort of disease, but typically it's saying that the arteries themselves are non-compressible and you're going to need further testing. So it doesn't give you a diagnostic confirmation of PAD. It says you need more testing to figure out what's going on. Less than 0.90 is diagnostic of PAD. Less than 0.90 on an ABI is diagnostic of PAD. And then it gets worse in severity. 0.5 to 0.9 is considered mild to moderate disease. 0.2 to 0.5 is considered severe. And typically you have critical limb ischemia, rest pain, wounds, and less than 0.2 is when you're going to see things like gangrene and severe necrosis. At that less than 0.2, that's usually when we have amputations occurring. 0.2 to 0.5, that one notch up on severity, or one notch down, I should say, is usually the tipping point. They're likely doing the less aggressive interventions first, but that patient population might also end up with an amputation. Something I haven't mentioned before is if a patient has resting intermittent claudication, that is technically a contraindication to exercise, because what that's telling you is that person has a critical limb. That person needs medical intervention. So especially my outpatient people, we have patients with PAD that are going to come into clinic and they may or may not have intermittent claudication, but there are other tells that we can look at in order to basically give ourselves a leg up on what we're seeing. If your patient shows on observation, right? So here's your observation things. I'm looking at the patient's legs and there is change in skin. Pay attention to what those changes are, because that's going to help determine what disease process is primary. And sometimes patients don't know, right? Especially in the outpatient setting, when you have less access to an EMR or just notes upon notes. Like in a hospital setting, I can view notes pretty much for the person's entire life if they were at that hospital for years and years. The access is unbelievable. In the outpatient setting, you don't always have that much information, right? So it's important for you to be aware of this, because you might be treating a different body part requiring exercise, and we have this underlying diagnosis that the patient might not know to say, hey, I have PAD, right? We all know it. We all know the picture. You ask what's in your past medical history, nothing, healthy as a horse. You look at the medication list and it's 20 deep, right? So we have to be able to use our observation skills to help weed out some of this problem. So with patients with PAD, we have decreased blood flow to the periphery, to the distal aspects, hands or legs, right? But it's more commonly seen in the legs. Things to look for: shiny skin, hairless skin. Looks like the legs have been waxed. They're shiny in appearance. They're almost like glistening, but not wet, just like shiny, as if there's light bouncing off of it. The skin is typically dry. Theirs tend to have like brittle nails or poor growth of their toenails. Usually kind of look not flat, but like elevated and brittle. I think that's the number one word that comes to mind. The color can be pale. Some say blue. You might even have like a pink tone to it, but usually pale is the primary finding. And the other thing you might see is wounds. And these patients who have wounds that have peripheral arterial disease are very pointed. So they're typically on the lateral aspect of the malleoli. They're typically on the toes. They're typically very dry and punched out in appearance, meaning it's like a perfect circle. It looks like someone literally punched out that wound. It is not wet. It does not have a lot of exudate. It is dry. It looks like we're not getting blood flow to that area. And these patients typically have a really hard time healing these wounds. These patients typically have long-term trying to heal, right? This chronic wound on their toes, this chronic wound potentially on their heels. It takes a long time. We have to be very aware of that. Now, why do we care about these other things if we're not treating that, right? And I'm just kind of thinking about my outpatient PTs right now, because I know we get the patient that has the comorbidities 20 deep, right? Not every outpatient PT is seeing the young, healthy athlete. I mean, it's just what it is. So we have to be aware of this. And if we're working with these patients on balance or increasing ambulation distance or improving quality of gait, then we need to be aware of the wounds that exist, because if we worsen those wounds, we might have a huge slide back for potential hospitalization because of those wounds. So something to really consider. A lot of times, and I didn't say this specifically earlier, patients that have PAD have diabetes. It's one of the risk factors. 1 in 4 diabetics have PAD. So not only do we have to worry about the peripheral arterial disease, but we have to worry about neuropathy and the diabetic wounds, and then their inability to heal. So if these patients are in your hospital setting, and they might be there for something else. I've had a number of patients recently come in for acute on chronic heart failure, but they also have, they also have this giant heel wound that is not healing. What is something that we need to consider? What is their weight-bearing status? Typically, they'll keep them toe-touch weight-bearing, partial weight-bearing, weight-bearing as tolerated with a 4-foot offloading shoe. But ask. These patients, when they tend to go non-weight-bearing, can be a huge slide in their overall function, ability to discharge home, decrease in independence, and then decrease in independence long-term. I think people really underestimate how much physical strength and aerobic capacity and balance is required for non-weight-bearing gait. And I am constantly blown away when patients have surgeries that will result in non-weight-bearing, and they have had no training preoperatively and have no idea how difficult that will be, right? Especially the elective type surgeries. I recently had a gentleman, non-weight-bearing, had Charcot foot. It was an elective surgery. He had a non-healing wound on his heel, or possibly the plantar aspect of his foot. Either way, he was elective, and no one prepped him that post-surgery he was going to be non-weight-bearing. But when I went to go and see him, he said he had been staying off his foot for the last 6 months. And what that meant was he just wasn't ambulating, but he was transferring, putting his full weight on. And of course, the guy is 6'3", like 250. Non-weight-bearing gait is a chore. It is very stressful on the body from a physiologic perspective, like watching heart rate, blood pressure increase with that activity. And also, do you have the strength? Do you have the balance? And more importantly, what is happening on the other leg? Like, we have to think about this, because if we have that patient non-weight-bearing and now they're hopping on their contralateral leg, you have to worry about existing wounds and or creating a wound. And that is real talk, super important for you to consider and have the conversation with your patients. Also, if you're in the hospital setting, we all know that most of our patients are walking in the hospital sock. I highly recommend, if your patient is diabetic and or has peripheral arterial disease, to put a shoe on. If they have a shoe, put the shoe on. If they're non-weight bearing, put the shoe on. If they don't have shoes, ask if someone can bring them. It seems so simple or maybe like minutia, but that is a super important thing to teach your patients that are adiabetic and or have poor chronic wounds. And if we are non-weight bearing with these patients, then we have to understand that the load on the contralateral side is at risk. The big concern with these patients is what is the intervention that will be performed. So a lot of times if these patients have chronic wounds or they caught it before they have a wound and they have intermittent claudication, they typically will do diagnostic testing like ultrasonography to actually see how much occlusion exists and exactly where the occlusion exists. It is pretty much the same process as CAD. So typically they won't intervene until there's 70% occlusion. That's the same as CAD. And how they fix it is the same. So they can do non-invasive type stenting. They can do atherectomies where they literally rotor it out. But not everyone has the ability to be non-invasive, and sometimes you have an open procedure. Typically, with any of these reperfusion type interventions, their weight bearing is tolerated. The non-invasive access, they may not even really need you from a physical capacity, but I'm telling you, the education is so important. So if you have these patients and they're moving just fine and you're seeing them even just for a quick check-in, give the education because it's going to give so much benefit long-term. And you might put the word in their ear that if they have severe PAD, they can qualify for cardiac rehab. And if you can do this patient any favor, it would be getting them to go to cardiac rehab so that they can learn about healthy eating, medication management, supervised exercise, and it be catered to them specifically. And the laundry list of other things that we teach in cardiac rehab that will help this patient, not just in this moment, but long term. I really think we need to get out of the habit of just responding and actually trying to prevent worsening in the future, right? Like you're already here in this position. We know what the sequelae is. You have PAD, great. We get stented or not. You get a wound, it heals or not. And then we start with the amputations. Toes, transmet, BK, AK. Then the other side kicks in. I've literally had 10 patients over the last month that are either bilateral BKAs, a BK and an AK, trying to hold off on the BK because they know as soon as it happens, their functionality is going to go completely down and lose their independence. So let's help. Let's figure out how we, as physical therapists or whatever profession you are, to educate, to teach the benefits of exercise, to teach cardiac and PAD risk factors to help this long-term sequelae. The amputation route is detrimental to patient independence, and it really comes down to their underlying condition, their ability to progress, their family support, and the ability to be non-weight bearing and actually perform that type of gait. It's a sad process to watch in the hospital when you know that putting this patient in a non-weight bearing position for likely 12 weeks is going to really decondition them. So what can we do to help mitigate that deconditioning? Upper extremity ergometer can help blood flow to those legs. It also can help maintain aerobic capacity. That endurance aspect, the ability to exercise and have a proper heart rate and blood pressure response is underrated. Like, if they can physically do that, then do that, because that's going to keep them in shape, conditioned, give purpose, create a habit that is going to then require longer term. And if we start thinking like long term, and this patient has a BKA, then we start thinking about prosthetic training. Prosthetic training can't even be in the picture if that patient isn't going to be able to tolerate it. They won't be covered. Now, I'm spoiled because I came from the VA, and we had criteria that the patient had to meet in order to get a prosthetic, but it was much easier for those patients to be admitted for prosthetic training and actually be in-house for X number of weeks until they hit independence. That is not happening in the private sector. I've had patients get prosthetics and barely have PT, barely have training. And then what happens? They spend a ton of money on this prosthetic and it's not even being worn. So just something to consider. I know I kind of went on a couple of little different tangents, but this is PAD, right? It's not just intermittent claudication. It's a sequelae of events. This is going to be your frequent flyer. The start is angina in the calf. The end result can be an AKA. And from a patient-independent perspective, that can be an absolute game changer. Think about home environment. Think about access. Think about family support. All of the things come into play. Sending someone to a sniff for X number of weeks and then returning home with no family support is likely still not going to be successful. So we have to really look at the whole picture, look at the person, and most importantly, help prevent the sequelae of events that we know is going to happen. All right, I think that is all I have for you. I hope that was helpful. I love treating patients with PAD. I love the training aspect of this. I love these patients in cardiac rehab. And I do love treating the patient post-amputation. But if we can help prevent getting there and help that overall decline, why not? We need to help our patients prevent sliding down that scale, okay? All right, I hope you all have a wonderful day, and whatever you have to do, get after it.